6 webinars focused on pediatric dermatology in ER. And with regards to those of the participants joining us for the first time, I work at Shifa International Hospital. I'm Dr. Amjad Khan, and I'm Pakistan's first UK-trained pediatric dermatologist. Although you can see I've done a fellowship in pediatric rheumatology, but that was out of interest, so that I can look after my patients slightly better. Now, we were talking about other conditions previously. This one is for, oh yes, let's do the disclaimer first. There is myself, our CME department and the hospital has no financial interest to declare. This is only a CME event and is for educational purpose only. Now, regarding the topics of today, we'll be talking about drug allergy, drug reaction, hypersensitivity reaction, EM, but in erythema multiforme, but in not much detail because it's part and parcel of dermatological emergencies, which I will be sharing with you in lecture 5 and 6. We will talk about infestations, including scabies and head lice, and some cyst, skin, lumps, and bumps. Now, with regards to drug hypersensitivity syndrome, what we label as slightly more focused on hematological involvement and systemic involvement, including eosinophilia and lymphadenopathy. Now, dress in itself or drug hypersensitivity has high fever. So just think about systemic involvement. Any child presenting with temperature and has rash. So temperature and rash, that's a very much common presentation in emergency department. But if you examine the child has got lymph nodes, yes, there is an infection, but lymph nodes, and then think about hematological abnormalities, which we will share. What are the few of them, along with internal inflammation of different organs, and again we'll talk about that as well. You can see one of the photographs. Now it's a significantly heterogeneous modality or skin presentation, drug hypersensitivity. So there is no diagnostic sort of clue apart from going through the whole of history examination and then putting the pieces together. Now, adverse cutaneous reactions usually constitute 2 to 3% of hospitalization. The most common presentation is maculopapular rash. Some people will have urticaria or angioedema. And out of that, erythema multiforme is one of the modalities or diseases or presentations. Steven Johnson's toxic epidermal necrolysis, DRESS, and Ayub. They are others. We'll talk about them obviously in the emergency lectures at the end of this webinar series, but today we'll be touching erythema multiforme and DRESS. Now there is a proposed criteria. There are different criteria, but this one is slightly more in line with the clinical practice. And you can see so temperature. That's the first thing which we talked about as well. But if you do look at hematological temperature and rash, and then hematological abnormalities, you have eosinophilia, so high eosinophils, presence of atypical lymphocytes if you do a blood film, and then systemic involvement, which is lymph nodes anywhere in the body, examining the child, liver involvement. So how do we pick up liver involvement? So transaminases, they are more significantly high in DRESS. Kidney involvement, so creatinine, interstitial pneumonitis, so you will have clinical signs, and carditis. Now, what does DRESS or any drug hypersensitivity involves. Which drugs can have those? Unfortunately, there is no one group of drugs in specific. You can see a whole list of them. Most common NSAIDs, antibiotics, and then other sort of antihypertensives as well. Now, main differential diagnosis for the drug hypersensitivity, you can see SJS and 10 is one of that, AJAP, but erythroderma, generalized redness scaling. Erythroderma is again a dermatological emergency, and then vasculitis and acute viral infection. Just to point it out here, I've recently been asked or consulted by one of my colleagues in another city remotely with regards to a young child. That was actually in the last 2 days. And we were thinking about vasculitis actually for that child. Post measles, generalized erythema, but it turned out to be leukemia. So please do look or think outside the box. Diseases don't follow the medical textbook. So please do think outside the box. Now, this is the differential or the criteria or differential patterns between the three conditions. And you can see DRESS or drug hypersensitivity is a long term. It's a sort of a longer duration. Typical onset is in few weeks rather than days like in Egypt. And again, fever, which is again common between all the three conditions we are comparing here, but infiltrated papules. So the skin itself is significantly infiltrated once you examine the child. So temperature, infiltrated skin or papules. Facial edema is very common. In Egypt, it is there as well, but that's with short history. So everything goes in line. Then lymph node involvement. Hepatitis, you can see at the bottom of the chart, and then high eosinophil counts. Now, pathophysiology is a potentially life-threatening severe skin eruption with fever and hematological abnormalities and internal organ involvement. Unfortunately, it has extremely heterogeneous presentations and is more commonly associated with HLA, different types of HLA. So obviously, it's sort of a research thing rather than just the clinical, but it's more seen in some Japanese patients and some other pharmacogenetic studies. Now, what is the treatment? So I will probably say initially it's supportive treatment for the skin rash because the child already has got temperature, has a skin rash and lymph nodes. And then obviously you look into the hematological bit of it. But so for skin rash, you can do dressing, topical corticosteroids, moisturizers, and antihistamine. That's the sort of basic supportive care. But looking at the extensive bit of it where the generalized systemic involvement is there. So please look at the polypharmacy. Look at the drug chart, look at what the child or the patient is taking, and discontinue the offending drug. Steroids are very widely used, oral or IV pulse methylprednisolone. Different regimens are used across the globe. So whichever you are familiar with, please do consider that oral steroids or IV methylprednisolone. But even despite using IV pulsed methylprednisolone, there is not much good outcome or much good prognosis if it's a severe sort of DRESS or severe drug hypersensitivity. The other drug you can use is cyclosporin, fantastic medication, a very sort of significant and improved results with it. Not only with regards to the patient, but for the clinicians when we are stuck and the patient is on steroids, you can use cyclosporin for the DRESS as well, refractory to steroids. The dose is the standard one, which is 4 milligram per kilogram per day. So now, theoretical involvement, if we look at the theories, there are a few things which could be helpful. There are case studies. So one of them is N-acetylcysteine. And there are case reports about it. But the other thing is interferon alpha, which is theoretical, which can help. So I couldn't find any case reports, but if you look around, people have talked about it. So watch out the space. It might be that someone is doing the trial as we speak, or using it in isolated cases. IVIG is widely reported, and there have been some case reports and case series. While desensitization is only for adults where they have associated with HIV polypharmacy. Now, in summary, it's a poorly understood phenomena. Susceptible individuals who have sort of issues with their acetylation and their liver metabolism have more commonly drug sensitivities, and the treatment varies by the cases. Steroids usually are the lifesavers initially, but cyclosporin is the backup, and then IVIG. These are the sort of three commonly used ones. And with that, we'll conclude the dress, but we'll move on to the next topic in line, which is erythema multiforme. Now, again, as I mentioned, erythema multiforme will be discussed in detail when we are talking about dermatological emergencies. But just here, a little bit background. It's acute, self-limiting, abrupt onset, fixed red papule. So this just gives you the whole idea within the two lines. And targetoid lesions are pathognomonic, mostly on the palms. Other parts of the body can be involved, and predominantly viral. So HSV1 and HSV2 are more common in young children. Now, this was first reported in 1860 as typhus annus, because it was in that patient occurring every spring, and was reported by von Hebra. Now, there is a Bryce criteria for EM or erythema multiforme. It's so it should be self-limiting, less than 4 weeks, symmetrical, fixed. But again, this criteria looks at retrospective rather than active lesions. Mucosal involvement is usually absent, or it's only one mucosal involvement as compared to the other SJS and TN, and compatible histology. Now, there is a bit of discrepancy or discussion between the academics here. Some people don't regard EM, erythema multiforme, as part of the spectrum of SJS and TEN, because what they describe or they write is that cytokines are different and the pathophysiology is different. So that's the reason people say don't use the term EM major. Some do, some don't. So I will leave that with yourselves, because wherever you practice, you can practice according to your local guidelines. This is a child with HSV infection, and it started on the lip, HSV labialis, and after that you can see it spread to the face and typical targetoid lesions, and especially on the cheeks as well. Now, with regards to the EM specific points, fixed lesions, you just think about acute self-limiting fixed skin lesions. Targetoids are typical but can be in evolution. Koebner phenomena is usually observed if there is trauma. So let's say if somebody has started EM lesions, and if they have any scratch on the face or arm, they will have erythematous papules there as well. Fever, lymph node are involved, and organomegaly are usually absent. If there are, then think outside the box, and it usually heals without any sequelae. Now, again, I follow the academics which say EM is not part of SJS spectrum, but as I've mentioned previously, you can follow the academics if you want to. This is a giant urticaria misdiagnosed as EM. Note the lesions clear in the center with normal skin in central zone. So even in erythema multiforme lesion, the central skin, if it is clear, it's not normal skin. So the difference between urticaria and erythema multiforme, you can see central zone or central skin is normal in urticaria, not in erythema multiforme. The lesions move in urticaria, while in erythema multiforme it's fixed at least for a week. Urticaria is usually associated with swelling, EM mostly not. And new lesions appear regularly in urticaria, while in EM It appears only in the first 3 days and then gets fixed. Treatment is symptomatic, again, oral antihistamine, antacids for oral ulcers, HSV treatment, and sometimes people have used oral steroids, but it's not indicated. Let's talk about scabies. I've gone a bit in detail in scabies and head lice because I've seen quite a lot of, unfortunately to say, but mismanaged cases in the last 2-3 months I've been practicing here. So that's the reason I wanted to take this opportunity to talk about the treatment and options of scabies and what to do and the precautions. We only think as a clinician, what I've noticed here, people only give prescription, a little bit of advice and nothing else. We have to educate the families how to avoid getting reinfected. Now let's talk about scabies. All of us know it's Sarcoptes scabiei. All over the world, it is common. It can happen anywhere. It spreads easily within the institutionalized patients, orphanages, old age houses, and usually the life cycle is between up to 2 weeks, and but the itch can sort of arise 4 to 6 weeks after the transmission of mite. So there is a latent period. If somebody gets the mite, it's not that immediately they will start showing the symptoms, because they have to settle down, start adult mite needs to, so it gives eggs, the female mite, and then what happens is the body's reaction to it, what we usually see as itch and irritation in the skin. So hence it takes between 4 to 6 weeks of lag period. Now adult mite lays up to 3 eggs a day for her lifetime, which is usually 1 to 2 months. And the scabies rash is a hypersensitivity reaction. Now, with regards to the type of scabies, we usually have typical, which is very common here. Atypical is mostly in immunocompromised patients, HIV, very old age, very young age, where they have not significant immune response and they cannot sort of defend themselves. That's the way the Norwegian or crusted scabies is more common. I've only seen one patient here fantastically responding of Norwegian scabies, fantastically responding to ivermectin. I will talk about ivermectin at the end as well. So you can see the schematic diagram showing where the scabies might hide and the life cycle of the scabies as well. And usually the scabies mite can live up to 4 to 6 weeks, and but it does not, one, it cannot jump. Second, it cannot survive more than 3 days away from human body. So please do think about it. It's not like that somebody in the room quite away or far from you, you will get the infection. So some junior colleagues I've seen, they are very in a very hurry to just give the prescription out to the scabies patient, just because I think they are worried that they will get it. But with the appropriate precautions, we should be safe, and it will be reasonably safe to educate them as well, the patients, before sending them out of your consulting room. Now, how it's spread, mostly the two common things, direct prolonged skin-to-skin contact or sharing clothes, towels, and bedding. Incubation period, I've already explained, 4 to 6 weeks because of the mite coming in, laying eggs, and our body getting reaction to that. And usually, if previously infested with scabies, symptoms may appear within few days if somebody's already infested previously and get reinfested again. Typical areas you can see where the scabies are, and this is for all of us, because when we are looking for this rash, when we have this scabies in our differential, this is where to look out for, watch out for. Very much common symptoms include pruritus, intense at night, positive history of skin contact in the family. You might ask and they say, yes, somebody in the family has been itchy. They wouldn't say scabies, they will say itchy. Yes. Oh yeah, he itches a lot. We don't know why. And have seen a lot of doctors, nobody can treat it. So some people only think about giving antihistamines, examine this patient, look out for the different parts of the skin, as already shown in other photographs. We'll again talk about that as well. So it's a direct examination of the skin, scraping and low power objective, dermoscopy or PCR. Usually PCR is not needed because clinical examination history is good enough for all of us. Treatment is not only the treating of the scabies, treating the symptoms, and then treating the complications. So anti-scabies medication, all of us are more interested that as clinicians, but let's talk about them first, and then we'll talk about other basic precautions. Permethrin is very commonly used. Benzyl benzoate, I've seen people using. Malathion is very commonly used, but I think it's short here, at least in our patch. And then Crotameton, again, this is very commonly used. I don't know how effective it is. It can be used, but if you see less response, I do prefer myself permethrin or even ivermectin, if depending on where you are and if it's available. Now, with regards to the scabies treatment, Malathion, the commercial name is Derbacam internationally. If it's licensed after 6 months of age. Under 6 months, the only licensed product is permethrin, which is again licensed after 2 months of age. And you can see how to apply. There is just remember the life cycle of scabies, and hence there is a week between the treatment. So one treatment now, one treatment a week later. The only difference is Malathion needs to be applied for 24 hours. So it's very much irritant to the skin. And the younger the child, the less tolerant they are of Malathion. On the other side, permethrin needs to be applied between 8 to 12 hours. So overnight, you can do the treatment. And if any area has been washed, needs to be reapplied, or again, the treatment needs to be put on. Basic precautions: apply after having a shower and drying the skin. Then massage the medication into the skin. Now, in adults, we usually say under the chin, but in old people, senior citizens, young children, toddlers, immunosuppressed, we usually say involve the whole body. And my practice of saying here is actually to tell them, leave the eyes, leave the eye area and apply elsewhere. And obviously the nose. So this triangle, and then apply everywhere else. But be careful. Again, for kids, I usually tell them that they apply while they're not asleep. So you can, see if they are sort of rubbing at one place and then going into the eye, you can at least hold their hands until the lotion, until the cream dries down. And then obviously it's less of an issue. And again, as mentioned, Malathion needs 24 hours application, while permethrin needs 8 to 12 hours. And now be careful when you are educating the families. Tell them that the kharish or the itch will persist even beyond it. So it's not that this treatment is to get rid of the kharish. This is to get rid of the reason for it. And then again, you can give them treatment for antihistamine, anti-itch, or anything, whatever you prefer. For isolation, now again, with regards to the clothes, because it hides in the clothes and cotton, bed linen, you can sort of wash them if it's not available, if washing is not an option for, because the things are way beyond that. They are a lot and very much. You can put them in a tight sealed plastic bag for 7 days, and change all the bed linen, towels and clothes daily. Again, it's a lot of, so what I turn around to the lady of the family here and tell them there's a lot of work for you. Are you on board? Are you happy to sort of involve all the households to help you getting rid of this infection, because it will otherwise go round and round in the whole family again and again. Slight additions to what we have already discussed. Treatment is best done at night before going to bed. And again, the other thing I would suggest is everyone in the household should be treated at the same time. I've seen quite a few families what they do, क्योंकि बच्चे घर में 4-5 हैं, तो what they do, there are 3-4 kids in the family. They will treat 2 one night because it's a lot of work, and 2 other night, and then themselves. So by the time they come back to the first one, it's already so it's not going to work. Everybody needs to be treated at the same time, otherwise they will get sort of reinfection again and again. Let's talk about ivermectin. Fantastic medication, easily available here in Pakistan, and very minimal side effects. It's for other sort of parasites as well. Some side effects, but touch wood, I haven't seen many here. For 5 years and older, you can use that easily because of the tablet form, and it's only 1 dose. And it's easy route of administration, only single dose, very effective, significantly effective. If you're worried, if somebody presents to you that they have, all the family had sort of, let's say, few times they've gone through to very many practitioners, and you're not winning. And it's very difficult for them to treat topically for the whole of the family, then ivermectin is an option. But remember, with ivermectin, it's not a single solution. They will have to do all the other precautions as well. Now let's talk about head lice. Now, head lice are nuisance, but they do not carry disease. It's not that it's like ticks or other things where they will transfer the diseases to the human beings. So don't worry about that. They live and reproduce on our heads, and they feed on the blood from the scalp. I've seen quite a few young kids presented as seborrhea here, and family says jin ko to sar mein khushki aur kharish hai. And you are observant, look closely, especially in the behind the ears and on the back, and you will realize with magnifying glass or dermoscope that between that khushki, between that flakes, they have a lot of nits. So please think outside the box. You can see one is beginning to feed, the other one is full of blood, and they are sort of these are the nets of the eggs. Now, what obviously I've learned through my training, my supervisor used to tell me, I learn as I teach. So that's what happens with all of us as we go along. We learn ourselves as well. So if the eggs or nets are at the base, the hair has not grown much, so they are possibly still active. The eggs or nets at the slight distal part of the hair has already grown. So that way, obviously, you can see that these are old nets, not new ones. And now a net name for adult, it takes roughly a month for the whole process and cycle, and they are much more active as compared to scabies infestation, because they lay up to 150 eggs, which is a lot. And only the thing is, only adults can lay eggs. So the transmission or propagation is with the adults only. So close contact must transmit live adult louse before the other person gets and the head lice as well. And they cannot fly, jump, or hope, and they are transferred with the personal belongings. So brushes, combs, hats, that's what I tell my patients here. Please separate your brushes. You don't use the hats or any head scarves or anything. Don't share that with the other people. And close head-to-head contact. So mostly in schools, if the kids are playing or they are sort of doing, now obviously with the COVID, we have got social distancing, so that's a bit more protective for our patients. Personal hygiene is always significantly better for all of us. Now, head lice cannot live and reproduce on animals, and it's only on humans. So just bear that in mind. Now, if kids are scratching, if you find any actively moving adult lice, eggs or nets attached to the hair shaft, nymphs, then that's what you're looking for when you're examining a child. And these adult head lice live for just under a month, and they die within 24 hours of being off a host. It's not that if you brush your hairs and they've fallen off, in another day or two they will infect anybody else. It's only for 24 hours they are live, and you can see, unfortunately, with the magnification they look so horrible. And so as I've already mentioned, they are babies, like small, they are then medium sized or nymphs, and then nits, nymphs, and then adults. And they usually mature about in a week's time. And the treatment, now again, with the treatment, we only recommend the treatment if you find active, live head lice or viable eggs. Now, this is the very close-up photograph. You can see it looks significantly bad if you look at a child. So quite horrifying, actually. I've seen one with extensive. I was literally surprised when I looked at her scalp that she had so many head lice. But the presentation was actually for kharish or khushki, seborrhea, and itching. So prevention, treatment, and treatment of belongings, as well as post-treatment inspection. It's very resistant to treatment, can come back again and again. It's not like scabies, because here, because the life cycle is different. Then if there are leftover eggs, they can hatch and again have the whole sort of within a week or two can have the adult again crawling on the scalp. So very resistant to treatment. So please, even if you have treated the patient, ask them to do sort of combing, the head lice combing, and ask the family to be vigilant and look around every week for next 4 to 6 weeks. And as you can see, frequent inspections are put on here as well, and personal belonging precautions, and all the household members daily need to have sort of inspection to make sure it's not moving between them. And now with the reason I put on this slide is bedding, all the bedding and personal belonging in hot soapy water. We usually say for 10 minutes is fine. And as a last resort, I've seen a patient and mom was not winning. So what she did, she said, well, bahut ho gayi, Dr. Saab, I can't sort of be bothered anymore. इसने भी बड़ा सफर कर लिया, हमने बहुत सारी दवाइयां इस्तेमाल कर ली. Bearing in mind they were reluctant for ivermectin as well, so shaved the child's head, and that was solved, and solution was actually shaving the head. So that's another thing to think about. Topical products are available, and head lice sort of treatment needs to be repeated every 7 to 10 days to see there are no nits left, there are no eggs left. And now the reason I put on this slide three different things actually. One, keep your product label with you, so whatever you have used, so that just in case you get a reaction because they are chemical irritants, you know what you have been using. Second is avoid eyes. In young child, make sure it doesn't go into the eyes when you're washing. They are irritant, they will significantly sort of chemically burn the child's eye, and it will be so much irritant you might have to end up in A&E or emergency department to see the eye doctors. Third thing, you can see the photograph, how to wash the head, because what happens if you wash it like this, standing, and then what will happen, all the chemicals will go on the body, and sometimes that can irritate a young child's skin as well. No close contact, and using the appropriate combing will treat the head lice. And again, avoid home remedies. कुछ लोग जो हैं, they have been using, some people have been using flea control products, so paint thinner and turpentine. So please don't use that, it's not effective against head lice. Educate your patients, and yes, if a child has head lice, you have found it out, encourage the family to share it with the school, so at least they know about the child, and the child has a bit of observation where they are not very much intermingling or coming close to the other children. Otherwise, what will happen, suddenly you will get a lot of patients from the same school or catchment area, because the head lice would have spread in all the kids. House cleaning, we have already talked about. You can do vacuum the surfaces which are not washable. Otherwise, you can wash things which you have access to. And the third option is sealed plastic bags for 2 to 3 days. Here, remember, so for scabies, it's 7 days. Head lice, it's 2 to 3 days. Think about helmets. So motorcycle use is a lot more here in Pakistan as compared to overseas. So helmets, do think about those, and car seats. And please don't use insecticide sprays. Sprays used for mosquitoes and other things, they are not very much effective for head lice. Now, discourage head-to-head contact and treat all the family as at the same time. School, think about the school kids to stop the outbreak. And head lice, you can use ivermectin, as I've mentioned as well, because it's used for any infestation as a last resort if need to be. And with that, I think we'll go to the lumps and bumps. Let's talk about cysts. So the commonest cysts in young children is epidermoid cyst. They're more on head and neck, but can happen anywhere on the body. And they are not like villous hair cysts or hair inclusion cysts, where it's on more on hairy part. These can be on, these are more common on non-hairy or parts of the body where there are little hairs. And it can arise in adult as well as young children. And I've seen quite a few actually. And you can see they're flesh colored, but they have flesh colored, but they are yellowish center. Sometimes have a punctum, like you can see here in the photograph. And they have keratin contacts, cheese like. It's not pus. Most of the families will come say, dekhiye jis bachche ko itna pus filled infection ho gaya. These are mostly non-tender. It can happen in adults, usually in the groin area, not in children. Other one is pilar cysts, and you can see these are on the scalp. Sorry. And otherwise, face and trunk, middle age, but young people as well. Sometimes they can be multiple, not in children, again in adults, and they're firm. They don't have any puncta, and you can see they're mostly in groups. And again, they have keratin contents in them. And now we'll talk about cysts. Most of them will need excision. Some will need wait and watch. So epidermoid cyst, you can do wait and watch if it's asymptomatic. But otherwise, most of the cysts will need excision, surgical excision. Steatocystoma, and they are sometimes multiple teenagers. Those are the group of patients you're looking at, and because of androgen effect, and they are usually persistent. You can do again excision. Some people advocate cautery, but again, see how the patient is, how much worried they are. You don't need to treat them willy-nilly just because they are present there. Try to encourage them to wait and watch and observe. And there is no central puncta on these, and you predominantly it's sebum, nothing else. So it's nothing to worry about. What our practice should be that we should tell families initially that it's nothing to worry. Is it something to worry about, or is it something not to worry about? And then give them the options. What are the options? And give them the time to think. यहाँ ये practice मैंने देखी है here in Pakistan कि you have to make the decision there and then. Sometimes difficult. They have got new diagnoses. They have so much information. Give them time. Ask them to go. These are the 3-4 options. Go and think about it. Dermoid cyst, very common in young children, and can have some include other structures, anything, teeth, cartilages, skin structures, and they always need to be excised. And they are usually small but present at birth. Now, digital myxoid pseudocysts or cysts, they need to be cut out as well. They can be in the nail area as well. So nail matrix, if they are pressing on nail matrix, the problem is the nail growth. And sometimes in adults, they can be involved with, they can be associated with osteoarthritis, but again, surgical excision is the treatment of choice for them. Milia, quite sort of multiple, very common young children, so neonates. They can be in the young children and can be in older people as well. One, you can use urea containing moisturizers. You can use, if not on the very much close to the eye, but salicylic acid based products. You can cautery them if there are two or three. Some people will use uh, sort of mild sort of surgical options, including, like I've mentioned, cautery, but they can, some people squeeze them out for the patients themselves. So there are so many options available, but because there are multiple, the more intervention we do, the more scarring they will leave. So always better to go for less of intrusion. Now, what I've seen other people using, there might be some case reports out there, is adapalene or different gel. It's used for acne, but it can sometimes help with mild milia as well. So just a practice or practical guide or an idea about this. So I do sometimes use that as well. Pilometricoma, very common. Well, at least in my practice, I've seen quite a few. Unfortunately diagnosed as so many different things by our colleagues. Because they look yellow, people think it's full of pus and they want it cut out. Well, they want surgery. So you can see the bottom photograph I put on, because there is a bit of mild erythema surrounding the lesion, so people think it's infected. Most of these are totally asymptomatic. Now, how you diagnose it, what you can do is a tent sign. So if you press one side of the lesion, the other side will go up. So this is a tent sign, because it's calcification. It feels hard and bony. I've at least seen two here in the last few weeks, and it can be present anywhere on the body. And they slowly grow. So one came and said, well, Dr. Saab, 18 mahine se hai, khatam nahi ho raha. Different doctor ne antibiotics di, baki dawaiyan di. When I examined the child, I said, well, this is pilometricoma. My practice is I will show them on the internet some photographs. If that relevant medical condition has medical information leaflet for parents, like British Association of Dermatology have written some, American Association of Dermatology or American Pediatric Dermatology is called as Society for Pediatric Dermatology, SPD. Then they will, I usually encourage them to go and visit them. For SPD, I think I've co-authored 7 of the information leaflets. For BAD, I think they are just developing few for pediatrics separately. With that, I will say thank you very much. And you guys have been fantastic. And I had, a very good time presenting here. And let's talk about few questions if we have. Yes, let's go to the. So someone has asked about recorded lecture. Yes, lecture will be recorded. It is recorded. Actually, it will be available on Shifa Hospitals CME sort of Facebook, YouTube channel. It will be available on my own website, dramjadkhan.com, and my Facebook page as well. And with regards to the certification of the session, yes, you can contact our CME team, and they will be more than happy to provide you. I think there is an administrative charge for that, so they will be able to answer your questions with regards to that. There's a question: what if drug can't be discontinued, like if a septic patient develops rash? Yes, very good point. Septic patient, if we are thinking about antibiotic as a cause of the drug rash, then we need to talk to our microbiologist. One, we need swabs, skin culture, blood culture, and then depending on the answers from there, we can talk to our microbiologist. There is always a second, third, or fourth antibiotic as an option, so you can switch between the groups. Other question is, cyclosporin be given to immunocompromised child? Any alternative? Well, cyclosporin is used for different conditions, psoriasis, eczema, in other problems as well. and it is an immune suppressant itself. That's the way it works. And if a child is already immunocompromised, cyclosporin, I'm not sure if your answer, you have to share the case, and then we can talk about it. Because if a child is already immunocompromised, why? HIV is uncommon in children on repeated steroids or regular like nephrotic patient. So cyclosporin will help nephrotic patient as well, the pathophysiology of the disease. If the child is on oral steroids or systemic steroids because of eczema flare, so cyclosporin will help with the eczema or psoriasis as well. So actually cyclosporin most of the time will be helpful in the whole scenario rather than just the drug reaction. So if you have any other question or anything specific, please do share and we can talk about it. Okay, now let's Q&A. We have got other questions. I'll answer a few of them. Okay, so one question is, so all painless dermoid cysts around lateral eyelid must be removed. Again, I think I've answered that question when I was delivering the talk. So what happens, it's not us making decisions for the patients. We are patient advocates. That's the way we have been trained overseas. And I'm sure that that's what my colleagues here will agree. What we do, we tell them this is a benign condition. Unlikely it will resolve. One option is wait and watch. Second option is intervention. What are the interventions? Surgical intervention for dermoid cyst. Painless, yes. But what happens if a child gets infection anywhere? Tooth infection, throat infection, anything, chest infection, ear infection. With any infection, unfortunately, the clinical appearances or the clinical practices that we see, these cysts, including dermoid cysts, getting inflamed. So बच्चे को गला खराब होगा, ये cyst बढ़ जाएगी, जिस तरह आप जिन्होंने लिखा है कि जी लेफ्ट lateral eyelid के पास है. So you get an infection, the child is under the weather, the cyst will get inflamed, and then they will come in an acute emergency saying the cyst is infected. So cyst gets inflamed but not infected, because that's an inflammatory process going on in the body. So if there is a systemic inflammatory response, cyst is part of the body. So that's the reason we have to educate them. When the child will be under the weather, there might be a flare up of the cyst. You can wait and watch. If you want excision, then the excision is available as well. Then let them decide. So the next question is, what is the cause of post-scabies itch? So, okay. So scabies, the mite byproducts cause itch. Although the mite gets taken care of by the medication, the mite dies with our treatment. We kill the mite with our topical or ivermectin treatment, oral treatment. What happens, the leftover byproducts are still there in the burrows. So those burrows or pockets are still on our skin. So as the skin grows, that will fill those pockets. And until then, that's the few weeks, the itch will be there. Sometimes it's 6 weeks, sometimes 8 weeks. I think that with that, I've answered all the questions posed to us. And thank you very much for all of you again. And hopefully we'll see you back on 8th of July. Please do share it with your other colleagues so that we have more participants and it's widely shared. And once it's on our website, YouTube, Facebook channel, please do share that link as well with your colleagues and junior doctors. So thank you very much and see you back on 8th of July.